Good afternoon, everybody. And I'd like to just give a brief overview of the EVD algorithms. And really, I'm speaking today on behalf of the EVD Scientific Advisory Committee. So the work represents the work of a lot of different people. So what I'd like to talk about over 15 minutes or so is to set the context for the discussion of the three scenarios, which you're going to hear after my talk. I would like to focus a bit on what happens before somebody gets to hospital, so describe the pathways for how suspected cases present to a hospital setting. I'd like to give a brief overview of the main points of the acute setting algorithm, and then also just mention the clinical care pathway for an adult, which has just been agreed this week. So a person with suspected Ebola virus disease may present to the acute services in probably four ways. And I suppose what I'm trying to make the point here is that the first three ways are ways in which you can get information in advance and know that somebody is coming. In other words, the GP would be referring, the ambulance service referring, or public health referring. And the fourth way is self-presentation without prior warning, where somebody just presents in an emergency department. So you can see that there are many opportunities to plan and prepare and arrange that a suspected case is identified and assessed in a controlled environment. So let's look at the GP pathway first. Now, if ideally a patient has contacted the GP by telephone, it may also happen that the person would present in the GP surgery. They present with fever and a travel history to an affected area, and there's no obvious alternative diagnosis. The GP then has the opportunity to contact the designated hospital EVD contact. Now, this is a crucial point. Each hospital has been asked to designate a hospital EVD contact point, and if you do that and provide it to your GPs, you can get prior warning of any cases coming from general practice. The GP, in consultation with public health, then arranges transfer to hospital by ambulance if required, and public health is involved. So the risk assessment can then take place in a controlled environment in the acute hospital setting. The second pathway is the ambulance service pathway. So if a patient presents to the ambulance service with a travel history and fever, the National Ambulance Service have an algorithm in place that they can directly contact colleagues in the National Isolation Unit and undertake a remote risk assessment. So the risk assessment is already undertaken by ambulance personnel in conjunction with the NIU before the person ever gets to hospital. And at that stage, if it has been determined that it's been a high-risk exposure, the National Ambulance Service can direct that person directly to the NIU. If it has been determined that there isn't a high-risk exposure, the ambulance then contacts again the important person, the local designated hospital EVD contact, and again you can have assessment in a controlled environment in the acute hospital setting. The third pathway is the public health pathway, and this is the context in which public health are monitoring contacts of a case. We heard earlier that the most likely type of contacts would be healthcare workers returning from affected countries, and public health will have undertaken a risk assessment and assigned these contacts as either having had high or low risk exposures. If those people present with fever or other symptoms suggestive of EVD, they do require referral for medical evaluation. Depending on the risk assessment of type of contact, that will determine where they will go. So if these are people who would have had a high-risk exposure, and the example this morning, a breach of PPE while caring for patients with EVD, they will be assessed in the National Isolation Unit. So if it was somebody with a low-risk exposure, again, public health will contact that person, the local designated hospital EVD contact, and assessment can take place in a controlled environment in the acute hospital. The fourth way is presentation to an emergency department directly by a person who didn't have any interaction with healthcare before coming to the emergency department. And how do you deal with preparedness for this? One is raising awareness in the waiting areas, and I think you probably all have the posters that you can put up in the waiting areas, and also, as I'm sure you have in place, triage, asking about fever and travel history, and if that's positive, immediately activating your in-hospital mechanisms. So the pathways to hospital, the important message really is that identification of the local designated hospital EVD contact available 24/7 is a key preparedness activity for each receiving hospital. And not only to have that you know within the hospital, but it's absolutely essential that this contact is provided to all the local GPs, to the ambulance service and to public health, so that in the event that they see any case, that they know exactly whom to contact. And I think that would really help in controlling the situation with regard to patients presenting cold to the emergency department. So the acute hospital setting algorithm is for use either when assessing patients with prior notification, as we've spoken about, and it's also used for patients who arrive cold in the emergency department without any prior warning. So you use it in both of those circumstances. And the principles really for use of the acute hospital setting algorithm are, you obviously need to consider the clinical circumstances in all cases, and obviously the algorithm should not impede delivery of safe and effective clinical care, which is the priority. You need to put the patient in a single room, and very importantly, obviously staff are concerned around this, but the patient themselves will be concerned. So you need to explain the process to the patient and really work hard to avoid the patient feeling frightened or alone or abandoned in the room. And you need to apply standard contact and droplet infection control precautions as discussed earlier today. At assessment stage, this is what is advised, and the PPE committee put out a statement last week to say that this level of precaution at this level is appropriate. This is the algorithm, and I'll just focus in on a few things in it. So the first kind of point of entry in the algorithm is, does the patient have a temperature or a history of fever, and do they have a relevant travel history, or alternatively, do they have an epidemiological link with a confirmed or probable case of EVD? If they do, then you're into risk assessment. And really, given the nature of the situation, we really need to involve a senior member of the clinical team to undertake that risk assessment. And basically, the risk assessment is trying to determine, have there been high-risk exposures or not? And I think Ireland's very lucky that the NIU has provided a low threshold for calling them. And at this stage, when you're undertaking a risk assessment, you are allowed and encouraged to contact the ID consultant on call at the NIU if you have any difficulty undertaking this procedure. So this is the list of the high-risk exposures. This is a busy slide. I've just bolded some of the key points. So some of them have been mentioned earlier today. So if you've had close face-to-face contact with a probable or confirmed case without PPE, or if you had direct contact with any material soiled by a person with EVD, or if you're a contact of a probable or confirmed case, or if you had unprotected sexual contact up to 3 months after recovery, or a percutaneous injury or mucosal exposure to the bodily fluids, tissues or lab specimens of a case, or participated in funeral rites or had direct exposure to any human remains of a case, or had direct contact with bats, rodents, primates or bushmeat. So if it's yes to any of these questions, it's a high-risk exposure situation. And as been emphasised this morning, you know, it's appropriate to, if you haven't already during the risk assessment spoken to the NIU, it's appropriate to discuss the situation with the NIU now. You do need to undertake the urgent investigations that are required for clinical care and management of the patient. And obviously one of those is an urgent EVD test. And on the algorithm, it gives you the details of how to consult with the NVRL and how to undertake that. So I presume you would have already contacted your local ID clinician, a microbiologist and infection control at this stage. If you haven't, it's really important to involve them at this stage, and also to notify the Director of Public Health. Why? Because the Director of Public Health will, in a high-risk exposure case, will need to be preparing for contact tracing and the setting up an outbreak control team in case the case is confirmed. So it's really important not to forget the public health dimension here at this stage. And then also, as was emphasised this morning, if you have a really, you know, a high-risk exposure, you think this could be EVD, you're discussing it with the NIU. You do not need to wait until the result comes back. So you should consider early transfer to NIU. So if any of the symptoms that you think are consistent with EVD and a high-risk exposure, I think we heard our clinician colleagues saying that they would like to take one of those cases earlier rather than later. So on the other side, and I think this is the vast majority of cases, if you've no to high risk exposures as outlined, EVD is really unlikely. And in this situation, you need to consider likely alternative diagnosis and undertake the usual tests that you would do, obviously including a malaria test, considering, again, what Jerry Sheehan said this morning. And if the malaria test is positive or you've identified another alternative diagnosis, you treat. And obviously, if the patient is improving, EVD is really unlikely and you don't need to do an EVD test. You can de-escalate your infection prevention and control precautions. But if you have an alternative diagnosis and the patient doesn't improve, then you need to reassess and then review in light of all the results. And at this stage, if you haven't already involved ID, micro and infection control, you need to, and probably also the NIU, and you need to discuss with the Director of Public Health, because at that stage you may be going on to do an EVD test. So then finally, I'd like just to talk about the adult clinical care pathway, which a lot of work has been done to clarify this for the system. And it really links the algorithm with the pathways into hospital and from there to the NIU. So what this pathway does, which is a relatively short document, it describes the likely routes of presentation to hospital, as I described. It could be the GP, it could be the ambulance service, it could be a public health, or it could be somebody coming cold to hospital. It gives a step-by-step description of the risk assessment, investigation, testing, infection control precautions, and notification to public health. It also emphasises the expertise and the availability of the NIU clinicians available during the assessment process. I think it's an important principle. We heard earlier some questions, how long is the patient going to be in the peripheral hospital? And I think that's a good question, because really I think the message is that cases will be transferred to the NIU. So if you're looking after cases, it's a temporary phenomenon, that the idea is that they'll all be transferred to the NIU. So the acute hospital is likely to manage the case for a short period of time pending transfer. Now, as Jack said, the NIU arranges the transfer at the National Ambulance Service. You don't do that locally. As soon as you're in discussion with the NIU and a transfer has been arranged, they make all the arrangements. For stable patients, the National Ambulance Service have a paramedic team trained on a continuous basis, ready to go exactly where they need to go. For patients who require critical care management, we think this is pretty unlikely. Hopefully, if we've good awareness and early detection, transfer will be done in conjunction with the Matter Critical Care team and the NIU. And Brian Marsh this morning mentioned a roster of clinicians that may be able to facilitate that. And then with regard to the practicalities, all patients who are transferred to the Matter will be admitted directly to the NIU. They won't come to any centre, and then the care will be provided within the NIU setting. So that's me.